Hello everyone and welcome to our module on depression. In psychiatry, the term mood disorder is used to describe patients who have an abnormal emotional state. And mood disorders occur along a spectrum. At one end are patients with sadness, they have depression. At the other end are patients who have extreme happiness, they have mania. And I talk about mania in another video. Major depressive disorder is the prototypical example of a DSM-5 depressive disorder. And one of the major features obviously is depressed mood, but there are lots of other features and you need to be able to recognize them. The first one is loss of interest in activities. This is called anhedonia. Patients with major depressive disorder will tell you that things they used to enjoy, like going out with friends or watching sports, are no longer enjoyable to them, and that's anhedonia. Appetite and weight changes are common in depression. Some patients will eat more and gain weight. Other patients will lose their appetite and lose weight. Feeling worthless or guilty is common, so is an inability to concentrate or make decisions. And many patients with major depressive disorder have trouble in work or school because they can't focus. Fatigue and loss of energy is also common in depression, and in any patient with excessive fatigue, one of the things in the differential diagnosis is major depressive disorder. We'll talk in a minute about psychomotor agitation and retardation and sleep disturbances, but these things are common in patients with depression. And then in any patient with a depressed mood, we worry about suicide, and so suicidal ideation and suicide attempts are also elements of major depressive disorder. Psychomotor agitation or retardation refers to increased or decreased activity caused by an emotional state. So psychomotor agitation means excessive motor activity. Often this is repetitious. Patients can report feeling inner tension. They can be fidgety or pacing. And patients with depression often have psychomotor agitation. Some patients with depression, however, are at the other end of the spectrum. They have psychomotor retardation, so their movements become slow, and so does their thinking and their speech. They're slow to answer questions. They can have a low voice and use very few words. These patients are exhibiting psychomotor retardation as an element of major depressive disorder. Sleep disturbances are very common in patients with depression. Many of them have difficulty getting to sleep. This is called initial insomnia. Others wake in the middle of the night. This is called middle insomnia. And still others will wake earlier than usual and be unable to go back to sleep. This is called terminal insomnia. There are also some patients who have none of these things going on. Instead, they have hypersomnia, so they're tired and sleeping all the time when they're in a depressed state. And it's high yield to know for your boards that patients with major depressive disorder have altered sleep rhythms. This has been well described in clinical studies. Their REM sleep starts quicker after sleep onset. This is called a decrease in REM latency. They also have an increase in the total amount of REM sleep. Slow wave sleep is the sleep that occurs right before REM sleep, so there's a decrease in the slow wave sleep. And then finally, all of these changes can normalize when patients are treated with antidepressant drugs and feeling better. Patients with severe depression can have elevated serum cortisol levels. It's not clear what the clinical impact of this is, but the higher levels of serum cortisol and the sleep changes are the two most well-described biologic changes that occur in patients who have depression. Depression-related cognitive impairment is also called pseudodementia, and this refers to cognitive problems that are caused by dementia. Recall that one of the DSM-5 criteria for major depressive disorder is difficulty thinking and concentrating and/or making decisions. And so when this feature of depression is prominent, the patient can appear to have dementia when they actually have depression. And it's very important to distinguish dementia from pseudodementia because pseudodementia is potentially reversible with antidepressant medications. So let's take a look at this table I've made on the screen here. In terms of mood, patients with dementia have a variable mood, whereas patients with pseudodementia are obviously depressed most of the time. The onset and progression of dementia is usually slow and steady in most cases, but it can be rapid in patients with pseudodementia. The classic example is a patient whose spouse dies and then that patient develops rapid cognitive decline over the next few months. That may be pseudodementia, not dementia. In terms of the cognitive disabilities, patients with dementia tend to diminish these and say, no, I'm fine. They try to cover up their cognitive decline. In contrast, patients with pseudodementia are depressed, so they will emphasize what they are unable to do. It's sort of an element of wallowing in their disease. When you ask questions to patients with dementia, they will try to answer you, but they're unable to because of cognitive problems. In contrast, the classic answer from a patient with pseudodementia is, I don't know. The patient is depressed and doesn't want to engage with the questioner. And then lastly, the suicide risk is relatively low in patients with dementia, but it's relatively high in patients with pseudodementia, and that's because their actual diagnosis is depression. To meet criteria and make a diagnosis of major depressive disorder, patients need to have at least 5 of 9 symptoms that are present for 2 weeks or more. The 9 symptoms are shown on this slide. The first one is depressed mood, and the remaining symptoms are usually remembered by the mnemonic SIGI CAPS. S is for sleep disturbance, I is for lack of interest, G is for guilt, E is for energy loss and fatigue, C is for concentration problems, A is for appetite and weight changes, P is for psychomotor symptoms, and S is for suicidal ideation. So in a board question, make sure that you carefully count up the number of symptoms that are present. The patient must have 5 symptoms present for 2 weeks to meet criteria. Many board questions will describe patients with only 3 or 4 symptoms. Those patients do not meet criteria for major depressive disorder and should not be treated with the usual drugs and other treatments for major depressive disorder. And then finally, there can be no evidence of mania. Patients who have symptoms of depression plus a history or evidence of mania, those patients have bipolar disorder. Patients with mood disorders, including depression, can develop psychotic features. Often they develop hallucinations or delusions. These only occur in patients with severe forms of mood disorders, usually a severe major depressive disorder or bipolar disorder. Importantly, the psychotic symptoms will always occur together with the mood symptoms. If patients have evidence of psychosis outside of mood symptoms, then they have something called schizoaffective disorder, which I talk about in the video on psychotic disorders. But if their psychotic features like hallucinations and delusions only occur in the setting of a severe episode of depression or mania, then they have a mood disorder with psychotic features. Besides major depressive disorder, the other important DSM-5 depressive disorder is called persistent depressive disorder. It's also called dysthymic disorder. This is essentially a low-grade form of depression. It's less severe, but it's more chronic. These patients have depressed mood most of the time. The diagnostic criteria require at least 2 years of symptoms and no symptom-free period lasting for more than 2 months. And then the DSM-5 criteria also require at least 2 of the following: hopelessness, decreased appetite, sleep problems, and low energy, concentration, or self-esteem. So in a board question, a patient with this disorder will not have 5 out of the 9 criteria for major depressive disorder, but they will have at least 2 of the following, and those symptoms will have been present for at least 2 years. Going back to major depressive disorder, there are a number of subtypes that have been described based on individual patients' behavior, and I've listed them all on this slide here. So patients with these subtypes will meet criteria for major depressive disorder, but then they have other clinical features that puts them into one of the categories listed on this slide. And we'll go through just a couple of these, a couple of the important ones in the next few slides. The defining feature of atypical depression is called mood reactivity. It's a core unique feature that is always present in atypical depression. This refers to an ability to react to pleasurable stimuli. These patients have major depressive disorder, but they feel better when good things happen to them. That defines atypical depression. Another feature that is common in patients with atypical depression is eating and sleeping all the time. Remember, I told you that some patients with major depressive disorder eat less and lose weight, and some have trouble sleeping. But in the case of atypical depression, this subtype of patients has increased appetite or weight gain, and they have hypersomnia, meaning increased sleep. Patients with atypical depression also often describe a heavy or leaden feeling to their limbs. This is a version of psychomotor retardation that they have. And then lastly, these patients tend to be very sensitive to rejection. They will report a history of interpersonal rejection that they are highly sensitive to that makes them very upset. In some studies, atypical depression was the most common subtype of major depressive disorder. And in older studies, patients with atypical depression were shown to have a better response to MAO inhibitor drugs. And for a while, patients who met criteria for atypical depression were often treated with MAO inhibitors. Other studies have now shown that SSRIs are also effective, and so these patients in the modern era are usually treated with SSRIs, and that's because MAO inhibitors have lots of side effects, and you don't get these with SSRIs. Seasonal depression is another subtype of major depressive disorder. These patients have a worsening of their depression symptoms in the fall and winter, and it's believed that one of the reasons for this is because they're exposed to less sunlight in the fall and winter. So one of the treatments that's used for patients with seasonal depression is phototherapy. In phototherapy, patients sit in front of a sun lamp like this for a few hours every day, usually while they read in the morning or some other quiet time. They do this in addition to other therapy, and the phototherapy improves their mood. Major depressive disorder is usually treated with a combination of psychotherapy and antidepressant drugs. There are many forms of psychotherapy that are used to treat depression. Two of the more common types are cognitive behavioral therapy and interpersonal therapy. In terms of antidepressants, the most commonly used drug classes are the SSRIs and the SNRIs, and I talk about these drugs in detail in the video on antidepressant drugs. These drugs take time to work, so you need to allow the patient to take the drug for 4 to 6 weeks before you assess the efficacy of the treatment. After 4 to 6 weeks, if patients are still symptomatic, there are a couple of options of what to do. You can increase the dose, you can add a second drug, or you can switch drugs. Unfortunately, there are very few head-to-head trials of SSRIs and SNRIs, so treating patients with depression is largely a trial and error process to find the best drug or combination of drugs that works. The only time there's really one specific drug that is used is in adolescence. Fluoxetine is the drug that has been most widely studied in adolescents who have depression, so it's usually first line. All antidepressants have been studied in adults, but only a small number have been studied in adolescents. For patients in whom psychotherapy and antidepressants aren't effective, electroconvulsive therapy is an option. We'll talk about this in a minute. And then lastly, patients who are thought to be at a high risk of suicide should be hospitalized until their mood is stabilized. ECT is electroconvulsive therapy. This is a treatment for depression that is performed under general anesthesia. The way ECT works is that 2 electrodes are placed on the patient's head while the patient is under anesthesia, and then electricity is administered with the goal of causing a seizure. ECT is highly effective for treating depression. We would use it much more often than we do if it weren't for the fact that it requires anesthesia and there are risks associated with the treatment. Because of this, we usually use drugs and psychotherapy first and only use ECT when those interventions fail. ECT can be used safely in pregnancy, so in women with severe depression who are pregnant and want to avoid taking lots of antidepressant medications, ECT can be a very good option. Beyond this, it's usually reserved for patients who have depression with certain severe features. So for example, if they have persistent suicidal intent, if they have depression with psychosis. We'll talk about catatonia later, but patients who have depression with catatonia have an indication for ECT. And then lastly, some patients with depression are so depressed that they refuse to eat, and therefore food refusal is a sign of a very severe depression, and that's an indication for ECT. The most common side effect of ECT is that it causes amnesia. So when patients have electroconvulsive therapy, they develop retrograde amnesia, meaning they can't remember things from before the procedure. They often don't remember having it at all. They also develop anterograde amnesia. This means that they are constantly forgetting things for a few weeks after the procedure. Usually the amnesia resolves over a few months. A couple of other practical things about ECT. For patients with bipolar depression who are on lithium, the lithium is often held before the procedure because it's been associated with worsening memory impairment. And then any patient who's taking a benzodiazepine is told to avoid those drugs before the procedure, and that's because benzodiazepines are anticonvulsant drugs, and they lessen the benefit of the electroconvulsive therapy. Besides these 2 groups of drugs here, most other psychiatric drugs are safe for patients to take when they are going for electroconvulsive therapy. Suicide, unfortunately, happens to some people with depression and also bipolar disorder and even other psychiatric disorders like schizophrenia. 95% of patients who make successful suicide attempts have a known psychiatric diagnosis. It's usually depression or bipolar, but may also be substance abuse or schizophrenia. Women make more suicide attempts but are less successful in general. Men make fewer attempts, but when they do try, they are often successful and more successful than women. The most common method of suicide is firearms, and therefore any patient with a psychiatric diagnosis who has access to guns is at increased risk for suicide. One way that's commonly used to assess a patient's risk of suicide is called the SAD person scale. It's a point scale that goes from 0 to 10. The patient gets 1 point for each element of the scale that is present. There's a point if you are male because males are at higher risk for suicide. There's also a point for age if you're a young adult or an elderly person. There's a point if you carry a diagnosis of depression because this is the highest risk diagnostic category. There's also a point if you've had a prior attempt. Patients who have had a prior suicide attempt are a very high risk group. There's a point if you use ethanol or other drugs, and there's also a point for loss of rational thinking, which means psychosis. As I told you earlier, patients who have severe forms of mood disorders like depression can develop psychotic features, and if that happens, that's a high-risk patient for suicide. There's a point if the patient has sickness, meaning a concomitant medical illness. There's also a point for having an organized plan for how the patient would carry out suicide. There's 1 point if there's no spouse or lack of social support, and then lastly, there's a point if the patient has a stated intent to harm themselves. So you total up all the points. If the patient has 0 to 4, that's a low risk patient, 5 to 6 is medium risk, and 7 to 10 is high risk. You can also break down suicide risk assessment by whether or not the patient has ideation, a plan, or intent. So suicidal ideation is very common. Up to 60% of depressed patients at one time or another think about harming themselves, but go no further than that. Once they have a plan for how they would harm themselves, that puts them in a higher risk group. And then the highest risk group are those who have an expressed intent, meaning they tell someone, I plan to harm myself at a certain day at a certain time using my plan. So the highest risk patients are those in whom all three are present. And hospitalization is the treatment for high-risk patients, whether it's based on the SAD person scale or some other form of assessment. You should also be aware that involuntary hospitalization is sometimes necessary for patients with depression who are at high risk of suicide. If the patient will not consent to hospitalization, then you can hospitalize them against their wishes, and that's because there's an absence of decision-making capacity when patients have a severe mood disorder. And I talk about decision-making capacity in more detail in videos in the behavioral science section. Usually, in order to hospitalize a patient against their wishes and without their consent, the physician has to document that there's an imminent risk of harm that is present if the patient is not hospitalized. Let's talk about catatonia. Catatonia is a behavioral syndrome. It's defined by the DSM-5. And we'll talk about the specific characteristics of catatonia in a minute, but basically you can think of it as an inability to move normally. You can see it in patients who have medical illness, but you also see it in patients with mental illness, especially depression, bipolar, and schizophrenia. And just like you can have depression with psychotic features, you can have depression with catatonia. It represents a more complicated form of depression. The first-line treatment is benzodiazepines. Electroconvulsive therapy is often used because these are usually cases of severe mental illness. And in general, you try to avoid antipsychotics. They are not helpful and can worsen the catatonia. Shown on this slide are some of the clinical features of catatonia according to the DSM-5. One of them obviously is immobility. Another one is stupor or mutism. These people generally do not speak. Negativism is resistance to instructions, and catalepsy means the patient remains in a fixed position. This is a common feature of catatonia. Posturing means resistance to movement, which is also common. And then the last two features are echolalia and echopraxia. Echolalia means the meaningless repetition of another person's words. Some patients who are catatonic will do this. Echopraxia means the meaningless imitation of the movements of others. This can also occur. We'll finish this video by talking about grief, and we'll first talk about typical acute grief. This is the normal response to loss of a loved one, and it usually progresses through the 5 stages of the Kubler-Ross model. According to this model, the first stage is denial, where the patient may say, he can't be gone, there must be a mistake. The second stage is anger. It's blaming someone else. This is your fault that he or she has died. The third stage is bargaining. I'll do anything if she could be alive again. And then the fourth stage is depression, and the fifth stage finally is acceptance. As people move through these 5 stages, they can have visions or hear voices of the dead person. That is common and part of normal, typical acute grief, and this usually resolves within 6 months. If it persists beyond 6 months, it's something else. We'll talk about that in a second. Now, even though typical acute grief can last 6 months, you need to also be aware, especially for your boards, that depression can occur within 6 months of loss as well. Patients who develop depression during the first 6 months of a loss will have symptoms that are more severe than grief. For example, they'll be unable to be comforted by others. They may feel worthless and have anhedonia. They may lose weight and they may have suicidal ideation. If someone has symptoms like this within the first 6 months, then you need to recognize that that person has developed depression. These symptoms are beyond what is expected in typical acute grief. And then complex grief is grief that lasts longer than 6 months and begins to interfere with functioning in daily life. And patients who have complex grief often go on to develop major depressive disorder. And that concludes our video on depression.